malignant breast diseases. Breast malignancy could be either primary or secondary. Secondary, any tumor in the body could spread to the breast. I've seen a pancreatic cancer metastasizing to the breast. We've seen melanoma metastasizing to the breast. So they are all called secondaries. Core biopsy proves it, and they will be treated just like the primary site. There are primary breast disease cancer. Primary breast malignancy could be either lymphoma arising from lymphatic tissue, could be sarcoma arising from the connective tissue, or the one we always talk about, the carcinoma arising from the epithelial tissue. So a core biopsy will always differentiate between the three of them, because lymphoma, the treatment for lymphoma is systemic treatment. No surgical intervention here. This is the importance of a core biopsy. Sarcoma, when you operate on sarcoma, this is the main treatment for it, but you don't need to take lymph node, because less than 4% will have lymph node metastases. Again, core biopsy will be able to tell you, is it a lymphoma, is it a sarcoma, because this will make a difference to your treatment. Now let's talk about the carcinoma. We need always to remember, breast carcinoma, either mainly arising from the ductal system or arising from the lobules. So I always tell my colleagues, remember the DL, ductal, invasive ductal carcinoma, invasive lobular carcinoma. But we also have carcinoma in situ, ductal carcinoma in situ, or lobular carcinoma in situ. I will stop here. Carcinoma in situ is a locally malignant. It has no potential of metastasis, while invasive, it already has breached the basement membrane, able to spread to distant parts of the body. And knowing this with a core biopsy will make a lot of difference to your management plan. Carcinoma in situ, ductal carcinoma, it's all the cancer cells are bound by the basement membrane. It's a matter of time before they breach the basement membrane and they turn into invasive. So we really need good local control here, but there is usually no systemic therapy. But lobular carcinoma in situ, once in a while, we used to treat it as if it is a cancer, but it's not anymore. It's a prognostic value. It means if you find it incidentally in a breast tissue, that this woman has a risk 4 to 8 folds increase in her lifetime. Let's talk about the invasive carcinoma. 85% arise from the duct, as I said, 85% invasive ductal carcinoma, but about 10 to 15% arise from the lobules, as called invasive lobular carcinoma. And then there are some other types of, like the medullary carcinoma, mucinous carcinoma, papillary carcinoma, but they all form together less than 5%. But they're all treated the same. Carcinoma in situ needs good local control. What is local control? Either a mastectomy or wide local excision and radiotherapy. The same for invasive carcinoma, but that's not enough. Now we need regional assessment of the lymph nodes to see if there is any attempted metastases, and we also might need systemic therapy to control any cells that might have spread through the bloodstream, like chemotherapy, hormone therapy, monoclonal antibodies, bisphosphonate if there is any bone metastases. So this is the difference between the carcinoma in situ and invasive carcinoma. Dr. Ashraf, الزيات, consultant breast surgeon.